So, good afternoon, everyone. I am Snehendu Konar. I am the Regional Coordinator of India of Avoidable Death Network. So, your moderator for today's important discussions on strategies to reduce avoidable snakebite deaths. And this is really a health issue that needs urgent attention. So, on behalf of ADN and Origa Research, I extend a warm welcome to all distinguished speakers, experts, and attendees from across the globe. So today's webinar brings together scientists, medical professionals, policymakers, researchers to discuss actionable solutions to reduce snakebite deaths, particularly in high mortality. So right now we'll begin with the opening song, a prayer, Ganesh Bandhana, performed by the Origa team, led by Rita Well, manager quality, Origa Research, and followed by yoga demonstrations later on by Kalyan Des team from Kolkata, highlighting the connections between the community well-being and holistic. So over to our team for class.
সেটা করে দাও, করে দাও, করে নাও, এন্ড স্লাইড শো কিছু শেখাতে হবে না, আমার এন্ড স্লাইড শো কোনো ব্যাপার নেই। সাইড স্লো করে রাখছি, বড় করে করা আছে।
Thank you very much, for this wonderful song. So I will request Mr. Kalyan Des team to display your yoga activity as well as the yoga dance.
Thank you. This is a wonderful program for the world. This will definitely help the snakebite victims. Now we will start our yoga session. This is the tradition and culture which is accepted by 177 countries in the world. So now we are starting our yoga demonstration. We all know yoga can cure some disease as well as it is a preventive measure for some diseases. it not only good physical, not only bring good physical health but also for spiritual and mental health also. So now just demonstration of little yoga show along with yoga dance. I think it will be enjoyable by all of you. So we are starting this. Just a second. গানটা চালু করে দিতে হবে। হুম। বজ্রাসন। পদ্মাসন। অর্ধকুর্মা। Change, path change. Bhadra. Tarason. Thank you all.
Thank you, Mr. Kollan and your team. It's a wonderful. So we have some activities done today. You know that the tree plantations at your campus. So the entire team was involved in this particular activity. So we'll show these activities right now, that what we have done. So this is a display, and that we are just in our campus only. There were tree plantations. Thank you. So, Kelly, Dr. Nivedita is already on, or might be she will be late to some extent. So, if because you are presenting on behalf of Dr. Nivedita, can you please check from Dr. Nivedita? Otherwise, we'll go to the next sessions of Dr. Saswata once, and then again we will start.
You can go to the next.
Okay, fine. So, can you please check with Dr. Nivedita once that if she can join after that?
Yes.
Okay. So right now that we are going to our main sessions, that is the session 2. The session 2 is on the strengthening healthcare response and community awareness. That expert talk is there, and Dr. Saswata Banerjee, I'll introduce himself. The topic is role of antivenom therapy, challenges and strategies.
Okay, so just give me a moment. Am I audible?
Yeah.
Yeah, let me share my screen. Is I'm audible for anyone? Can please check and let me know.
Yeah, pretty much audible. Loud
Audible,
and
audible. Thank you, thank you. So is my screen visible to everyone?
clear. Yes, sir.
All right. Thank you, Mr. Konad, for inviting me in this noble cause of Avoidable Death Network program on the snakebite. I think it's a very important topic. All of us are here to for one single cause, like how we can avoid the deaths due to the snake bite. Bites are not avoidable, but definitely deaths are available. But if we have to, if we can, and for that we need to have the right steps, starting from the prevention to the treatment and followed by the complications. But most importantly, that everybody should have that understanding of the awareness that what are the right things to be done at the time, rather going for panic and doing a lot of mess if there is a bite happen to anyone of us and in the community. So as a responsible the people in the healthcare industry, as well as from the healthcare fraternity, and also those who are here who are associated with this noble cause, we should play a very important role here to come forward and spread the right message to everyone that what are the right things to be done when there is a bite for anyone. So this is my introduction slide. I head the medical affairs for Bharat Serum vaccine, which is one of the largest manufacturer of ASVS in the country, with the clinical background and followed by the experience in the industry. Now, coming to this is my always whenever I go for any talk, I prefer to give kind of an sensitizing the whole problem. And this number speaks a lot. Though there are a lot of doubts about the number of bites in India, number of deaths due to these snake bites, but more or less whatever numbers are available globally as well as India, so there could be somewhere around 3 million, which is 30 lakhs of estimated snakebite cases in the country. But in reality, which are reported, which is much, much less, probably, 3 lakhs to 4 lakhs, which are the reported number. So these are few of the news clippings which are there, and you will find that of late these newses will come up on the newspaper, especially during the monsoon time, during the high season time. But I think that awareness need to be sustained at the all throughout the year. So now I'll move to my very specific the topic, which is on the anti-snake venom, because there are many talks which will cover on the data, which will cover on the other strategies, on the awareness and what can be done, the management and everything. I'll keep my talk very restricted on the anti-snake venom serum. So for everyone to understand, those who are into, in the practice and associated with the snake bite management, they are very much familiar with this. But for many others who are not directly involved to that, so snake bite, when the snake bite happens, the ASVS is the only main treatment other than the other supportive care and the other therapeutic managements. So if ASV or anti-snake venom is the main treatment, so we should know that what it is, how it is to be used, what are the dose, and what are the challenges. Now, ASV is manufactured from the horses or mules or from the ponies. These are of two types. One is the monovalent, which is very specific for a species of the snake, and the other one is polyvalent, where multiple snake venoms are pulled. The venoms are then injected in the horse, and the antibodies are produced. It is purified, fractionated, and then it is made. So polyvalent snake venom is available in our country. Uh, Other countries, they have the monovalent as well, but for our country it is the polyvalent, and that too against the big four. Big four, we all know, it is the common cobra, Russell's viper, common krait, and saw scale viper. Now, sorry, these ASVs or ASV or the antivenom, whatever name we say it, is constituted of the purified concentrated FAV-2 fraction of, it's a component of the immunoglobulin, which is enzyme refined, which is enzyme refined by the pepsin digestion method. And this immunoglobulin is actually extracted from the horse, mules, pony, as I told, by hyperimmunization method against the venom of these four poisonous snakes in India. Now, this advantage of this 5-2 lies in that it cleaves off the FC segment of the immunoglobulin, which is actually very species or the sensitive, which can lead to the immunogenic reactions or anaphylactic reactions. So when the 5-2 is actually clipped out, it reduces the chances of the adverse reactions. And more or less, when the anti-snake venom is injected, the adverse reactions are generally becomes mild or milder. In some cases, there could be a serious adverse event as well. But by this methodology, the adverse events are reduced. Now, each ml of the ASV, sorry, yeah. So each ml of these ASV, as per the level, neutralizes 0.6 milligram of the Russell viper and common cobra venom, 0.45 milligram of common krait and saw scale viper venom. So each vial contains, generally the vial which is available in a country are 10 ml vial. So the 10 ml can actually, you can easily understand the 10 times of that. Now, generally for any victim, the minimum of, minimum could be anything, but on an average, 20 to 30 vials are required to neutralize the venom which is injected during a bite. And this is available in either a liquid form or in lyophilized form, but it requires to reconstitute. And so I'll next slide, I will show you that how it is to be given in what dose. It is to be reconstituted and then injected intravenously in the patient. Now, if ASV is indicated, which is based on either the signs and symptoms of the envenomations, with or without any evidence of the laboratory test. But laboratory test should not be a stopping factor for administration if there is a definite bite happen and there are signs and symptoms of the envenomations are there in the patient. It is very important. So that if we wait for a test report, the sample sent to elsewhere, if we delay, that will delay the treatment, and delaying the treatment can lead to a grave outcome. Now, all these dosing schedules are actually recommended by the STG, the Standard Treatment Guidelines on the Management of Snakebite by the Government of India, published in 2016, and later little editions are done in the 2017. The doses are generally for the neuroparalytic snakes, 10 vials to be started immediately after the decision is taken that the patient require ASB, and that will be given over 30 minutes, followed by the second dose of the 10 vial after 1 hour if there is no improvement within an hour. Now, it can be supported by some tests, like very commonly the 20 minutes whole blood clotting test is done. Many other tests are also done before administrations to just check whether this is how the progress is happening clinically as well as from the laboratory test as well. For the vascular toxic snake bite, two regimes are commonly practiced. One is the low dose infusion therapy, another one is the high dose intermittent bolus therapy. Now, the low dose infusion therapy is found to be as effective as the high dose intermittent bolus therapy, and also saves unwanted use of the ASB drugs as well, because this is a very precious and a important medicine. So it should not get wasted as well. Wherever it is not required, it should not get infused. Now, for the low dose infusion therapy, if it is confirmed a Russell Viper vial has happened, then 10 vials, and 6 vial when it is confirmed, like a saw scale viper bite has happened. It should be the same duration, should be reconstituted, followed by diluted in a 500 ml of the normal saline, and then it is infused. Now, for the second bite, which is in the saw scale viper, the 6 vials are given, and then followed by 2 vials every 6 hours as infusion in the 100 ml normal saline till the clotting time normalizes, or for 3 days, whichever is earlier. So beyond 3 days, there is no point. By the time the venoms are already bound to all the target receptors and these tissues. In the high dose intermittent bolus therapy, again 10 vials polyvalent anti-snakebite serum given for 30 minutes, followed by 6 vials 6 hourly till clotting time normalizes and or local swelling subsides. So this is the more or less the two strategies which are adapted for the neuroparalytic and the vascular toxic snake bites. Now, important is the administration of the snake bite only to be done by the IV route, slowly, in presence of the physicians who is competent and experienced of use of this drug on the patients. Should be there on around, because immediately after the infusion there are possibilities of kind of reactions and other the change of the hemodynamic parameters and the other parameters of the patient as well. Now, I will conclude my talk. This is the last slide I'm coming, which is probably the other aspect of the ASBS therapy, which are the challenges and the strategy. So I have divided this whole thing into 4 major segments where you have the problem. So when we know that ASBS is the mainstay of the therapy of the bite, then we should know that ASBS should be given at the patient at the right time, right patient, right time for the right duration and the right dose. So what are the problems which can lead to break of these whole chain at any given point of time? One is definitely whom we are infusing or administering this drug on the patient. So is there any challenge for the patients? There are challenges. All of us know that, as I started with, there are lack of data, which is the biggest challenge, that how you can make any policy or plan or even manufacture the product when you don't know what is your the number of patients and leading to the number of vials required, which is your magnitude of the problem. So data is a problem. Second problem is the patient does not reach to the hospital on time. So what do they do? Either delay at home or go to the other, the faith healers or other people for, some kind of, respite from this bite, which they believe that which is traditionally happening. Because this problem is for age old. Ancient time also, we had snake and human conflict and the bites had happened. So that time there was nothing. So they were depending on kind of the other therapies. So we all know only 20-25% of the patients actually reach to the hospital. So that is another challenge. Third is delaying in the reaching to the hospital. So that is because of some problem. Either there are not transportation service, ambulance service, or car, or any other way means of transportations. Last is inappropriate or inadequate treatment received before reaching the hospital. So there are few do's and don'ts when a bite happens, but it is very not very widely and uniformly practiced by the patients. So this leads to the problem of the treatment, because when the patient reaches, now if it is delayed, if you infuse ASBS, so it's not going to work in those patients. And there are many number of patients which is the larger than those who reach, they don't get that access to the treatment. So we all of us need to think how we can mobilize the patient to the center where the treatment is being offered, how they can access the right scientific treatment. Now, coming to strategies, what we can do to mitigate this problem, strengthening the national registry reporting and data collection to address the problem of the data, that what is the my problem I'm addressing to. Number two, strengthening the outreach and the rural healthcare facilities so that you need not to travel much distance. All the centers which are outreach in the high risk zone should be empowered, should be equipped with the facilities where the treatment can be offered to the patients. Not only the facilities, but also the healthcare manpower, as well as the healthcare staff which are trained enough, as well as the experienced enough. Faster patient mobility. Faster patient mobility, if some arrangement can be done, like the transporting the patient either to the nearest center, or at least some number is given so that the patient should not look around how to reach there. So there are a few, definitely that has improved, but there are a few areas where still the connectivity is a problem. So that can be a strategy. Now, related to the treatment, the patient has reached. Now the treatment has to be offered to the patient. Who will offer the treatment to the patient? It is the healthcare professional. They will offer the treatment. So we need the expertise in managing the snakebite victims, including the management of the complications. So that is something which also sometimes, creates kind of a doubt whether I should administer ASBS or I should transfer to the next level of the referral hospital. Because if there is some complication, I don't know how to manage it. So that is sometimes, deterring the healthcare professional to infuse the ASBS or administration the ASBS. Detection of the envenomation and initiation of the treatment. Sometimes the signs are very dubious. A patient does not show a very clear sign of the envenomations, but still complaining about the bite. Is there any methodology which can pick up the bite earlier, envenomations earlier, and then that will lead to faster initiation of the treatment? Then comes the availability of the advanced medical facilities in the, the spoke and hub model, where the patients are treated basically with the basic treatment, and then if the complication arises, shifted to another center where the facilities are available. So these are sometimes the challenges. How we can overcome, I think one definitely is the skill development, mandatory and the periodical training of the healthcare professionals. It can be through the public partnership. NGOs can, take this initiative like Avoidable Death Network. Dr. Priyanka Kadam, she is, doing many other centers are there. So NGOs are there working extensively with the at the grassroots level to create that kind of, the training. At the same time, the government is also doing their own way. So we can strategize that, sending experts who can share their case studies, experiences that can be done. Dedicated centers, and that has to be, the awareness, or the campaign, that this is the dedicated center for your region or your zone, in your districts or your mohalla, tehsil. So that can be also created and also made others to aware about it. That leads to the awareness. I think one of the challenge, which is also the awareness level, that patients should also come forward and seek for treatment in these kind of problems, rather going to an alternative therapies, which are sometimes delay the right treatment to access or can cause death to the patients. So early identification of the snake bite related signs, what are the do's and don'ts before going to the hospital, are very important. Next is where to go, as I told, and then where to refer for the healthcare professionals. Like, if a small nursing home receives a patient with snake bite, are they equipped to treat the patient? Or if they're referring, where are they referring? If they're referring to another center, which is also not equipped, that will delay the treatment initiations or the right treatment. But these are very practical problems. So in any state, if you pick up, I think these are the problems in every state. It is the government hospitals who are probably more streamlined, more equipped, they get the training. But there are thousands and lakhs of the private medical centers. They receives the cases, but their doctors, medical officers are not probably, well equipped, well trained, well experienced with the snake bite management as well. Last two things which are there in this awareness category: trust on the faith healers and the other treatment, and the last one is the lack of media attention. I started with the news clippings, but sometimes the news are not made for the right customers. This new news is fine for us to discuss and everything, but in a vernacular language for people who are, so it is not the only newspaper media, but the electronics medias. The now today is the world of, the Facebook, Insta, and everything, the reels and everything. We can create something so that the right customers, which are the village people, the rural people, rural India, they should actually get the right kind of message related to what to be done at the point when there is a bite, and what not to be done. So if something can be created for them, who can quickly watch in their mobile or somewhere, and then get educated. So this is something which we can work out with, like, streamlining the referral system, media campaign, awareness camps, which many of the NGOs are doing every day, but more frequently can be done. Manufacturers can play a very important role educating the HCPs. They are limited to only HCPs. Last thing is about the current ASVS. There are a few gaps which the experts are identifying, constantly giving the feedback to the government, feedback to the policymakers, feedback to the manufacturers. One example I can take, there are need of the regional ASVS as well, because the species are changing, not changing, are different in the each regions. There are prevalence of the few snakes which are not there in the some other regions. So ASVS created based on the venoms which are pulled from one zone may not be effective for the bite which is happening in a different zone, because the snakes are different, the venoms specifications are also different. So this ASV may not be fully effective against the venom which is of the same species but from a different zone, because the venom quality and the venom specifications are also different. So researchers are working on that. That is one challenge, and that can be overcome through research and definitely standardization of the taste, coming out with the regional anti-snake venoms. Also, explorations of the possibility of inclusion of other species like monocled cobra, green pit viper as part of the polyvalent anti-snake venom, which is currently available against the big four. Last thing, administration and the considerations of exploration of the co-medications like repurposed medicine like, Verespladi or marismastad. So with this, I close my talk. I'm sorry if I have taken little extra time for this talk.
Thank you. Thank you, Dr. Sasanda. It was really a valuable perspective on role of antivenom therapy and challenges and strategies. So if the audience has any questions, please drop them in the chat. We'll take them during the question and answer session from 4:50 to 5. This is Kevin. Anyway, Dr. Nivedita, the ADN president, couldn't join yet. So I'll request Abdullah, if Abdullah Umar is available.
Yes, I'm ready. Thank you, and sorry for the mix-up. Please, can we turn on our camera briefly, a minute for a group photograph? Sadia and Ken will probably do that. Just a minute.
Okay, fine. So Umar, if you can just present the ADN and IAD4HD, okay, that will be fine, because on behalf of Nivedita, that if you can present.
Okay. Okay. All right, Kelly, if that's
Apologies.
done.
Yes, we
Okay.
have received a message from Prof. Nivedita. She will present Avoidable Death Network when she joins in a
Okay,
few minutes.
she's joined.
So
All
we
right.
can
Okay, no problem.
proceed. Thank you for switching on your cameras. Sadia, is the picture on?
All right, is that done?
Yes, it is done. Thank you all.
Okay, Kelly, can I continue?
No, Prof. Nivedita will present.
Okay, all right, that's good.
Thank you. We can proceed the session. Snehandu, please.
Might be that to some extent late. So Umar, that I'm moving to the next session because
Yes, we can proceed.
just next time honored to invite Dr. Manish Ranjan, AVP Auriga Research, to share his insights on today's topic. Before that, just I will introduce Dr. Manish. So Dr. Manish is the Vice President Corporate Arbo Pharmaceutical Limited, Auriga Research Private Limited. And Dr. Manish is an important member of management team of the group comprising with the Auriga Research Private Limited and Arbo Pharmaceutical Limited, Food Safety and Healthline, labtrainings.com, and he is having more than 20 years of extensive understanding of pharmaceuticals, healthcare, food, IUS, clinical, analytical industry, especially in the areas of training and audits in the strategy, planning, business development, and he is a doctorate in management with the PhD degree and a study of international of small and medium enterprises in subject. And he has a lot of corporate training and trainer for the lead auditor, ISO 90001, ISO 27001, and internal auditor for ISO 17025. Laboratory learn management and supply chain management, SAP, certified professional, AFISM simulations, the greatest corporate leaders of Indian Awards 2013. And he was the youngest achiever of the year in the year 2013. He plays an active role in the transformation and international of the group of the commenced several new initiatives to accelerate and implement the growth plans of the group. Thank you, Dr. Manish. Over to you.
Thank you. Thanks for the introduction and providing me an opportunity to be a part of this active event. A warm welcome to all and greetings from our side. Even for the first time, I came to know about myself. Thanks for my colleague. So here I'm with a different perspective. I am here because I'm not a knowledgeable person. I'm here because I'm surrounded by the most knowledgeable persons and industry experts, subject matter experts like you all. So I am having some different thoughts on that. And what I try to take the input and to make this event as an output and as an industry professional to make it a feasible, workable, sustainable, and scalable solution to the society. that we are here and why I am here for this. The topic is very relevant to all of us. It is not related with any industry, any profession, or any science group or pharma like that. It is for all of us. It is like water, it is like food, it is a survival. So either we are a urban or a city or in all rural, all environment, it is equally relevant. And especially for this event, it is truly global event with different time zones, participants from India, Nigeria, South Africa, US, UK, and many other parts of the world. Am I audible? Is it okay? So as you have observed that we initiated with a prayer and the tree plantation activity at our premises. So prayer is like to thank the ecosystem and also the awareness of goodness with a positive outcome. That was our motto behind that to initiate with. And the tree plantation is a sustainable solution for this because it controls the ecosystem with many solutions. So that was the activity. And even we are responsible for this problem, the deforestation. We are in a process to enter their snakes home. They are native, and this is the reason they are towards us. So that we have to again rethink into it, and we have to do accordingly. So what my motto is, addition to discuss these venom, these remedies, like we also discuss the positive part of it. Snake is our friend, not a fear that we look into. There are many societies where snake is being prayed as God, even in India also and in many other cultures. So we should also discuss the positive aspects, right? Snakes are natural pest control, air purifier, crop protector, contributor for the research, drugs, and medicines. So that way we look snakes as a friend, as a equally contributor for the survival of the environment and society. So now as a group, Orica, we are a 40 years old organization, and we had two initiatives. Sorry, will you please? Initiated, we invented, there are two websites. One is Food Safety Helpline. So this is a glimpse of that website. This is the website. And this is for the awareness of food safety to the consumer, regulator, and society as a whole. Another website that we launched and we have been operating, that is a platform, that is www.lab-training.com. This is again for the awareness of technicality, technical aspects of academia and industry, and a contributor to the skill development awareness. So my motto, and I also look forward being an industry professional, to develop such platform where we can have something like a Snakebite helpline or something awareness, which can be awareness program to the mass, not only like with the medical and technology point of view, with the aspect that yes, we have to reduce this, we have to make snake as a respectable and friendly creature, not like a fear. That is our motto, and that is my view for the participation of this program. So I'm fortunate for this session addressing, and though only 5 minutes allotted to me, I guess I have to conclude this with these words. So thanks to the government bodies, NGOs, all participants, WHO, and Global Snakebite Initiative programs, along with the media partners. All the best wishes from my side. Thank you.
Thank you, Dr. Manish. It's a really valuable insights and in general you can say, but still it is very effective. If the audience has any questions, you can post in question and answer session. Also, we'll discuss this. Next, we want to welcome Dr. Dayal Bundu Majumdar. Okay. So Dr. Dayal, just I think that in this particular area, many people knows. Just a formal introductions. I will attend Dr. Dayal is a senior medical officer, TNMCNH, and is a resource person of the Snakebite training and technical advisor of ICMR. So over to Dr. Dayal, and your topic is utilization of healthcare providers for early snakebite treatment. Yeah, Dr. Dayal, you can unmute yourself. Dr. Dayal, you are mute. You are in mute.
Radha, please unmute yourself.
Dr. Dayal, yeah, you just unmute because we cannot hear you.
Yes.
Yes. No.
Am I audible?
Yeah,
Yes, sir. Loud and clear.
Actually, I was trying to share my screen.
Yes, it's already there. Venom response
Yeah.
team, PRT.
Is my screen visible?
yeah.
Yes.
Yeah. Today, I am presenting one good idea for early hospitalization of snakebite patients. Actually, Dr. Surajit Giri of Assam has tried it successfully in Assam, in Sibsagar district. What is venom response team? Its objectives are to rationalize utilization of government fund for prevention and early treatment of snakebite victims, and reduction of government expenditure for snakebite death ex gratia, and rational utilization of trained informal healthcare providers IHCP, and breaking the unscientific age-old dependency on faith healers. What is the background? We know 58,000 snakebite deaths per year in our country. In West Bengal, in the year 2021, in financial year 2021, 607 cases were given death ex gratia for death due to snakebite. Actually, we know when some people tries to get some government fund, anything like ex gratia or anything, only half to 1/3 people get successful in getting it. 607 death ex gratia cases were successfully given 1 lakh rupees per death. So we can easily assess that the death were nearly 2,000. And 90% of venomous bite cases are manageable at the block primary health center levels. And 75% bite cases attends OJAs first. OJA means faith healers. Till date, 75% cases don't come to the hospital directly. Snakebite deaths are grossly underreported. You know, in our publication, we have shown only 20 out of 183 deaths were reported from one region of South 24 Parganas in our study time. What is being done at West Bengal? Presently, we have a very good state protocol for snakebite management since 2012. It is time tested. For last 13 years, we are successfully practicing this protocol. Treatment is available in all bedded health centers and above hospitals. In West Bengal, all the bedded health centers, maybe a primary health center, are equipped for treatment for snakebite deaths. snakebite cases. And 90% of our medical officers are trained. And IHCP training is going on. What is IHCP? IHCP is informal healthcare providers. Informal healthcare providers. Informal healthcare provider means coax. In common language, we call them as coax. They are being trained by government institutions. There are nursing training schools throughout West Bengal. 29 nursing training schools are giving training to the coax. And the service of this IHCP can be utilized as venom response team volunteers. In Assam, what Dr. Giri is doing, they have trained these Apoda Mitra volunteers. Apoda Mitra volunteers are a group of people who are trained in the non-government capacity. They are purely volunteers. They give them a government I-card. Some preliminary training is given to these Apoda Mitra volunteers. These Apoda Mitra volunteers are now successfully working in Sibsagar district of Assam. Our trained healthcare providers, these quacks, they can do it better in West Bengal. The IHCP's motorbike can be utilized as a motorbike ambulance. IHCP can operate ambu bag on transport. When the patient on a neurotoxic snakebite patient is transported from a grassroots level hospital to a higher center, particularly when the patient is on assisted ventilation, we don't have trained technicians or trained doctors everywhere to accompany the patient in the ambulance. These ICPs can be utilized. Millions of rupees are being spent for death ex gratia in West Bengal. ICP volunteers can be given some amount of incentive for carrying these patients to the hospitals. We have seen this incentives for ASA workers. ASA workers in West Bengal have made it successful. That is institutional delivery of all the mothers, institutional deliveries. Almost 99.9% of pregnant mothers are registered with the ASA workers, and they get some incentive for that. And these ASA workers take these mothers to the nearest hospital for institutional delivery. For that also they get some incentive. Actually, if one pregnancy case is registered with an ASA, ultimately after successful institutional delivery, this ASA gets nearly 1,000 rupees per pregnancy cases. Incentive can be given for carrying these snakebite patients to the hospital. How this funding can be done? Funding may be from National Health Mission. National Disaster Management Authority, funding for Apoda Mitra volunteers of Assam as VRT volunteers. Fund utilized for giving death ex gratia for snakebite deaths may be utilized for prevention of snakebite deaths by early hospitalization only. Rupees 1 lakh for snakebite death are given as ex gratia in West Bengal now. And this amount varies everywhere in India, not less than 1 lakh. In Odisha, it is 4 lakhs per death. Rupees 6.07 crore as ex gratia was given in 2021 in West Bengal. I have calculated here the required amount of incentive for the IHCP volunteers. It will be not more than 1 lakh total bites in West Bengal. So rupees 100 per case of IHCP, that is incentive per year will be only 1 crore rupees. And we are spending 6.07 crore as ex gratia. I have made a complete project report and submitted it to the government authorities. I have sent it by email to the Chief Minister of West Bengal on 29th August 22. It is more than 2 years is over. And hard copy was given to the mission director, National Health Mission of West Bengal, Director of Health Services West Bengal, Principal Secretary Health West Bengal, and Dr. Susanto Roy, Officer on Special Duty, and Dr. K.N. Mahato, Member of Standing Committee in West Bengal Health. The CMOH of West Midnapur district was agreed for a pilot project in his district. VRT model may be started as a pilot project in the West Midnapur district. Pilot project for the calendar year 2023. And data of pilot project will be analyzed in January to March 2024, and VRT model may be started in whole West Bengal from 1st April 2024. It was my proposal, but it is not yet accepted. So this is my proposal, and I have already officially submitted this in August 2022. Let's hope that our policy makers will accept this proposal, and Snakebite patients will be brought to the hospitals early by our venom response team, that is trained IHCP workers. Thank you all.
Last minute.
Hi, thank you, Dr. Dayal, for your insightful presentations. It was really effective because you know that at the community level and what needs to be addressed right now currently. Thanks. And if the audience has any questions, I have already told, because there might be that from the audience there might be questions relevant to this topic particularly. That really this is a topic that should be addressed immediately at ground level, the ASA, the leads and everything. So anyway, thanks, Dr. Dayal. And next we'll go to the next sessions that will be given by Dr. Priyanka Kadam. So a hot topic is primary health system strengthening and system level interventions for tackling snake bite and venoming in India. And I'll introduce Dr. Priyanka. So Dr. Priyanka is the founder of Snakebite Healing and Education Society, cindia.org, a national level civil society aimed at preventing and controlling snake bites. She is an expert in snakebite prevention and control strategies and has been a member of WHO's Global Snakebite Envenoming Group Working Group, which developed a strategy to reduce snakebite related deaths and disabilities by 50% by 2030. Priyanka collaborated with NCDC, National Center for Disease Control, and WHO India to draft the NAPSE, National Action Plan for Snakebite Envenoming, released on 12 March 2024. With the integrations of snakebite into the National Health Agenda, India has emerged as a pivotal stakeholder in driving the strategic execution across select states. Priyanka has published open access peer-reviewed papers in Transactions, Royal Society of Tropical Medicine and Hygiene, False NTD, Toxicon, X-ray, X, and Cochrane Library. He collaborates with the ICMR, NCDC, NCD, NHM, WHO India, and state level forest departments in 4 states, state level health departments in 6 states, and grassroots NGOs and missionary hospital in 12 states. So over to Dr. Priyanka.
Thank you, Dr. Konar. Thank you for inviting me to present in your program. Am I audible and can you see my screen?
Yeah.
Okay.
You are audible.
Okay. So I represent Snakebite Healing and Education Society. This is a civil society that works on snakebite mitigation. And we have been working for the last 14 years on snakebite. This society was registered about 8 years ago. So today I'm going to present on primary health system strengthening and system level led interventions for tackling snakebite envenoming in India. And this is basically an open access paper that we have published in January of 2025, very recent one, in the Transactions Journal. So any of you who are interested in reading the paper more closely, you can download that. It's available on the internet. But I'll talk a little bit about the primary health, the importance of primary health centers, and the strategy, how we can reduce the death and disability. Background is 58. One second. 58,000 deaths annually in India and 4 times more number of disabilities. So that is the highest in globally if you compare it with other countries with similar burdens. As some of the speakers have already shared, that the species responsible for maximum number of deaths and disabilities are 4: the spectacled cobra, the common krait, the Russell's viper, and the saw-scaled viper. So it does not mean that that there are no other species, venomous species in India. It just means that especially the 3 species, the cobra, krait, and Russell's viper, these 3 occur very close to human habitations. They are habitat where they have to live, where they hunt, rodents and lizards and frogs. It's abundantly found near human habitation. So they are not forest dwellers. They are very much living, amongst us. And also the saw-scaled viper, earlier it used to be more found in arid places and grasslands and all that. But because of a lot of deforestation and also habitat loss, there's so many projects are getting built on lands which had the habitation for the saw-scaled viper. So nowadays we see a lot of bites from the saw-scaled viper also. Now, let's look at a typical snakebite scenario in rural India. So, a family, when a person gets bitten by a venomous snake, the family will first indulge in faith healing. And when the patient worsens, efforts are made to find an ambulance to transport them to the nearest PHC. PHC is Primary Health Center. Now, the primary health center doctor takes patient history, administers a tetanus shot, and gives 1 vial of antivenom in envenoming cases. This is something that happens in many of the states. It's not that it happens all the time, but it happens in many of the states that we have worked, and we have worked in 12 states till now. As per the India Snakebite Standard Treatment Protocol, which was published in 2016 and then got updated in 2017, the loading dose for kraits, cobras, and Russell's viper is 10 vials and 6 vials for saw-scaled viper envenoming before referral to a higher hospital. So giving this 1 vial just to, not to avoid an anaphylaxis is actually a myth. Even in 1 vial, an anaphylactic shock can happen. Now, distance to higher hospital is anything between 5 kilometers to 125 kilometers. And this I'm talking within a district. Most cases are sent without ventilator support, and many neurotoxic bite cases from kraits and cobras, they succumb on the way to a tertiary hospital. Now, let's look at the India's health budget. So in this year, our health budget is 1.97% of the GDP, and it is 0.07% higher than last year. Now, this year, they have actually allocated some funds to build new medical colleges and all that, which is a good lead because there is a lot of paucity of doctors in India. There is so much of vacancy in the rural healthcare centers. So this is a good stand. But despite that, health spending remains below the recommended 2.5% of GDP, which was recommended by the National Health Policy, which was published in 2017. So National Health Policy had advised this with the focus that some budget was allocated in that policy for the upliftment and betterment of the infrastructure of the rural health centers, like the primary health center, the sub centers, and also the community health centers. Now, rural India's medical infrastructure requires significant improvement, including emergency equipment, trained staff, stocked pharmacies, and pathology labs for effective emergency response and referrals in critical cases. The current primary healthcare model addresses only 15% of the health issues, mainly pregnancy, childcare, and national health programs. Expanding its scope to treat medical emergencies is crucial to treating snakebite cases at the PHC and CHC level. Now, let's look at the primary health center in India. So a standard PHC should have 4 to 6 beds, operate 24/7, and employ at least 2 doctors, 3 nurses, 1 lab technician, and 1 pharmacist to serve 30,000 people in a regular area and 20,000 in remote regions. But many PHCs are understaffed, lack emergency facilities, experience frequent outages, and some remote centers have no running water. Frequent referrals of untreated snakebite victims to distant district hospitals delay critical care, increasing the risk of poor outcomes. High vacancies, shortages of qualified professionals, inadequate infrastructure, and weak regulation hinder care quality, worsening the number of deaths and disabilities in rural areas with the highest burden. So over the years, since the last 7 to 8 years, we have been doing doctors training at the district level. And with the interaction that we've had with rural doctors, we have compiled the reasons for referrals of PHC and CHC to district hospitals. So, and this list is also mentioned in our paper. So lack of trained medical personnel capable of managing snake bites. This is one of the biggest reasons for referrals. Absence of antivenom and necessary supportive drugs, inadequate respiratory support equipment, apprehension about anaphylaxis following antivenom administration, cases where the snake responsible and the physical signs and symptoms of envenomation are unusual or atypical, which means that patient party has probably brought a cobra or a crate, and the patient is suffering from coagulopathy. So in such cases, the doctor is confused, and they think it's better to refer the patient than to keep them and have a complex case on their hand. Insufficient beds available for patient admission at PHCs, patient families being uncertain about the treatment provided at PHCs, concerns regarding potential violence from the patient's family if the condition worsens, absence of a pathological laboratory for diagnostic purposes, especially in viper envenomation, and lack of blood bank, investigation facility, and dialysis machine or qualified technicians at the PHC and CHC level. Here we share some of the pictures of PHC infrastructure across India. And this is the picture of wounds inflicted by venomous snakes, and why this kind of a serious necrosis and this kind of serious wounds is because of unscientific first aid. So most of the times people, they tie a tight tourniquet, they cut the wound to flow out the venom. They think that, when they flow out the blood, the venom is also going to come out with it. Sucking of the bite area. All these things are totally unscientific, and it leads to serious recovery consequences for the patient, and also delayed treatment outcomes. That is also the reason for these kinds of serious cases of wound management. And lastly, I want to finish my presentation with talking about the Snakebite Assistant app. Since we talk about untrained, medical professionals and first responders, this is the Snakebite Assistant app. It's a teaching tool for self-learning. It has different profiles in this app. It is available in the Android and also the iPhone version. You can download it from the Play Store. And if your profile is of a primary health center doctor, then it basically teaches you how to prepare a case report, what are the various parameters to be used to assess a patient. And once you add the parameters of the patient, then it guides you how to, whether the patient has been envenomed or whether you still have to wait for some more time. This way it basically guides, how a doctor has to react while treating a snakebite patient. This app should not be used to treat snakebite cases. It is a learning tool. So it has to be learned, when you have free time. And obviously the app does not tell, what is the dose to be administered, because those kinds of decisions have to be made by the doctor on the ground. The app also has the secondary hospital doctor level. Secondary hospital means the district level, where referral cases come. That is not the first point of contact of a snakebite case. So, how do you, what are the things that you have to do when you're receiving a snakebite patient from another hospital? Those kinds of things are mentioned. It has many other information. So maybe you can just download the app and have a look at it. And that is all that I had to share. I've got 10 minutes. I'm not sure whether I have taken some extra time. These are my coordinates. If anyone wants to get in touch with me for any kind of collaboration, any kind of discussion, happy to connect. Thank you.
Thank you, Dr. Priyanka, for nice presentation. It's a really good, and it is a learning for that entire ecosystem, and it was insightful. Really, we learned in fact something new from this presentation. Nice, thank you. And just one thing, that our keynote speech, that our keynote speaker, Dr. Nivedita, it was a little delay, that it was at the beginning, but unfortunately that she couldn't join. So she had joined already. So welcome, Dr. Nivedita, and she is the founding president of Avoidable Death Network, ADN. So Dr. Nivedita will present the keynote speech and introduce ADN and IAD for AD 2020.
Thank you, Snehandu. Thank you, Priyanka, for your presentation. I think I've taken a picture of your last slide. We would definitely like to do collaboration. We have a model called Case Stations. So it's one of the smallest unit for research, for outreach and impactful work. And I have been experimenting it in the district of Ganjam in Burujari village. And we found the similar problems. One of your slides identified, the problems that are happening at the PHC and CHC level. So we run these outreach workshops every 6 months. So it would be either in the month of June or March, and then later on in October. So last year, Snakebite, Madras Crocodile Bank gave us some of their products, and we were able to showcase it to our case station people. So these are the high-risk population. So I really liked your app that you have developed for the health facilities service providers. So we would really welcome you to come in the month of June. So I will be traveling in the month of June to India, and Hideyuki, another co-founding president of ADN, will also be traveling from Japan. And then a few other technical experts of our Snakebite group will be joining me. So we would really welcome you to come and tell us a little bit more about your app to our CHCs and PHCs in our case station area in Ganjam district and also in Balasore district. So in Balasore, we are trying to do a collaboration with Fakir Mohon University. So we are also launching a case station. So your amazing product, or if you have any other products that would benefit the vulnerable population and also the service providers. So we would really appreciate that, so that people can learn and benefit from your products, scientific products. So thank you very much for sharing your findings, and also I'll read your article as well. So thank you very much for that. Esteemed colleagues, participants, and our future leaders, I'm so sorry I'm late. It's just that this event was registered very late. The deadline was 20th of February. I know Snehendu is very busy, but we are very grateful to have him. So it was registered a bit late. And this entire month we are celebrating the global campaign, and I'm a little bit stretched. I'm just invited to join often at last minute. So I'm sorry, because I have another parallel commitment at Imperial College. So I'm joining late, and also I have to leave because I have to attend that another event that started also at 10:30. So I'll try to finish my presentation in 5 minutes. I think Snehendu has already introduced me. I won't take much time, but one thing I just want to add, that in addition to Avoidable Deaths Network, I'm also an associate director at the Institute for Environmental Futures, which is also based at the University of Leicester. So we can move to the next slide, please. And I think the reason for this presentation is that this event, this webinar, is part of that International Awareness Day for Avoidable Deaths. And we just want to raise awareness a little bit about this Avoidable Deaths Day amongst our participants. So I won't take much of your time, literally 5 minutes. So a little bit about Avoidable Deaths Network. It was launched on 12th March 2019 by Hideyuki Shiroshita, my long-standing research partner. You will be able to see him at some point. And myself at the 4th Summit of the Global Alliance for Disaster Risk Institutes at Kyoto University in Japan. First slide, please. Don't rush it. If you could go back to the previous one. ADN is a global local membership network of experts, practitioners, researchers, passionate citizens interested in avoiding human deaths from natural hazards, naturally triggered technological hazards, and human-made hazards in low and middle-income countries. But we also work in high-income countries. I'm based in the UK. Hideyuki is based in Japan. And we also have another proactive regional coordinator based in Canada. ADN has more than 1,000 members. They have all grown organically. We don't have money, so we don't put in any kind of advertisement or anything. So we are very pleased that last year we hit this 1,000 members, and these members are spread across 94 countries. And ADN exists to help policymakers, researchers, practitioners, and at-risk and high-risk vulnerable populations make better decisions to save lives and reduce injuries to achieve sustainable development. And we understand avoidable deaths are premature deaths, and these deaths can be avoided through tailored preventable measures, treatable measures, and risk governance measures. So we can move to the next slide. So now a little bit about our global campaign. We call it International Awareness Day for Avoidable Deaths. We can move to the next slide. So this global campaign was launched on 12th March at the city of Izumiotsu in Osaka. And we did this in collaboration with the city's mayor called Mr. Menamide Kenichi. You could see him right on the top of the slide. That's Mr. Menamide Kenichi. And the global campaign was headlined by DADEN, United Nations Office for Disaster Risk Reduction Head, Ms. Mami Mizutore. The global campaign is celebrated annually, and we invite you to celebrate this global campaign. I know it's towards the tail end of March, but it's an annual event. You can celebrate it next year. I also welcome Priyanka Kadamji to celebrate this global campaign, because we have common interests and we are, passionate about saving lives at the end of the day. So I welcome Priyanka Kadamji to celebrate this global campaign, and other speakers who have joined this global webinar. This is a 10-year global campaign. On the 11th year, we will drop the word awareness. So we hope that in 10 years' time, we would be able to achieve our target is about raising awareness about avoidable deaths, and we have some targets. So last year was our first year. We wanted to reach out to 10 countries. And we surpassed the target, and we were able to celebrate the global campaign across 12 countries. So year 2, our target was 20, and we have surpassed that target as well. So next year, most likely 30 countries that we would like to reach out, but we have decided to probably take a step back and reflect and maybe solidify the relationship with these 20 countries a little bit more and raise more awareness. But it's not always the number. But yes, we do have a target to reach as many countries as possible over 10 years' time, and then drop the word awareness, and we will then just celebrate International Day for Avoidable Deaths. This global campaign was launched on 12th March. 12th March is ADN's birthday. That was the day ADN was conceived. But as I said, our members are spread across 94 countries. So we celebrate the global campaign throughout the month. And almost every day, a global campaigner is doing something to raise awareness in the local level. We can move to the next one. So a little bit about the global campaign again. Sorry about the background noise. My dog just decided to join in. Just must have seen someone at the door. So sorry about that. So yes, a little bit about the global campaign. So the global campaign has 4 purposes. So there's a typo on the PowerPoint slide. Just ignore that. So number 1 is to raise the visibility of disaster deaths, especially indirect disaster deaths. So because my background is disaster risk reduction, I got into the field of snake bites because snake bite is an indirect disaster death. And if you look into the million death study and some other research, we see that most of the snake bite deaths are happening during the monsoon season. And that's the season is also the flood season. And I have been working in the state of Orissa since 1999. I'm not Oria, but I have been working in the state of Orissa since 1999. And now the government in 2000, I think 15, 18, they announced snake bite as a state-specific disaster. And the snake bites are now, the number of snake bites incidents are included into the natural disaster annual report in the state of Orissa. So that's how we got into the field of snake bites. So we want to raise the visibility of indirect disaster deaths and also missing persons. Second purpose of the global campaign is to increase the visibility of the causes and circumstances that lead to disaster deaths so that context-specific interventions can be put in place. And I'm very fortunate that I was able to join and listen to Priyanka Kadamji, and the circumstances that she identified are exactly the kind of circumstances that the global campaign would like to raise amongst service providers, as passionate citizens and other learned individuals who are working in this field. The third is to promote the slogan, disaster deaths are avoidable. And as I said, we believe that they're avoidable through preventable measures, treatable measures, and risk governance measures. And the fourth one is to value the lives saved and reflect on the achievements of saving lives. So wherever there is an opportunity, we like to highlight the work, the scientific work that our individuals and institutions are doing. For instance, Priyanka Kadamji's app, and recently someone from Pakistan sent us some information about their frugal innovation that they came up with to reduce well-fall deaths. So this year, ADN has come up with a new award called ADN Hero Award. And this Hero Award goes to individuals who come up with some context-specific solutions to save lives. And this year, that award has gone to Pakistan, to this wonderful emergency officer lady called Tahira Khan. And as I said, she just came up with a very frugal innovation, a construction just around the well, and that has saved many lives in the district that she is working. So if you know anybody who has come up with some, frugal innovation, context specific, and have saved lives, just nominate that individual, and we would be happy to give them the ADN Hero Award. It does not need to be one person, it could be many, because saving lives is not one individual can do it. It's a multi-sectoral issue. Decision making is decentralized, and it's a systemic issue. So we would be happy to give awards to as many heroes as possible who have saved lives. We can go to the next slide, please. So the theme for the global campaign is do one thing. It can be anything. It could be a webinar like Chloe Vasquez, our future leader has done it. It could be a rally, like our regional coordinator in Bangladesh has led out a rally with her students. It could be a webinar, like our Snehandu, who has just organized this webinar to raise awareness about snake bites and also the scientific research that are ongoing. So it can be anything. We leave it to the campaigners to decide. We don't prescribe that. So we can move to the next slide. Just to help with the global campaigners, we have some cultural assets which are available to download from our website, which is called International Awareness for Avoidable Deaths. You don't need to pay anything. It's free of cost. There are 13 key global messages. You can just cherry pick the one that you think is relevant to your context. We have a handbook for guidance, guidance for campaigners handbook. Again, you can download it. There are lots of ideas what individuals can do, what government organizations could do, what journalists could do, you know, some ideas on how you could celebrate the global campaign and why we should do it. And we also have this graphic, disaster deaths are avoidable. You can download that. There are two colors, blue and green. It just represents the planet. The planet is blue, the planet is green. So that's why we have these two colors. And we also encourage our global campaigners to use the hashtag Avoidable Deaths Day. And we also have a toolkit which would allow you to record causes and circumstances of avoidable deaths. If you need that toolkit, you just have to send us an email directly. Next slide, please. We can jump, I think, because of the constraint of time. Just one note, I want to say that Avoidable Deaths Network is a member of the United Nations Sendai Framework's voluntary commitments. Our commitment is for Target A and Target B. Target is to reduce disaster deaths by 2030, and Target B is to reduce the number of people affected by disasters by 2030. And these two targets work at the interface with several SDGs, Sustainable Development Goals, 3, 9, 11, and 16, and few more. If you look into the snake bites, there are certain more targets also for drowning that we look into. For drowning, I think nearly 8 or 9 SDGs that in a way addresses drowning. So our global campaign is aligned with these targets, and that's why we are very keen to raise awareness, and we report to Sendai voluntary platform annually. We can move to the next one. So I think this is my last slide. I just want to thank Snehandu and our esteemed speakers and the participants for taking the time to join this webinar. These are some details. If you are not following ADN, you can follow now. We have the information up on the slides. We have Instagram and LinkedIn, which are pretty proactive. We have websites, ADN. If you haven't joined ADN, you can join ADN. It's free of cost. You can also follow the global campaign. I just want to say one note is that this global ADN is, it's not an NGO, not a trust, not a foundation. It's just a network based in 2 universities, Leicester University, where I am based, and Kansai University in Japan. And this network functions or operates purely based on volunteers. So we have no paid member of staff. So everything is done by the volunteers. We have nearly 20 operational members who are volunteers, and they have full-time job or full-time studying, and then they generously donate some time to ADN. So whatever we have achieved today is because of the volunteers, for the generous time that they contribute to ADN, and they believe in this goal of saving lives directly or indirectly. So I want to thank the entire team, Kelly, Fahim, Sadia, Mariam, who have helped and worked tirelessly to organize this workshop. And also many thanks to Snehandu for organizing this. So with that note, I'm going to stop, and I hope this session is going to be absolutely amazing, enriching, and impactful. So over to you, Snehandu. Thank you.
Thank you. Definitely. It's in ADN, it's nice because we expected in the beginning might be that it's a delay. Anyway, so entire team, I think it is visible that we are sitting and we started with Ganesh Bandhana and everything. You missed it. I'll share you the recording versions of these things. And there was the activity of tree plantations outside the campus. We dropped the work for life, but we did plantations. So I'll see the interesting pictures and videos, and some media coverage will be there. So I'll share with you. Thank you. Thank you very much.
1 minute,
Yeah.
Snehinda. I just see that your entire colleagues are there. So I'm so pleased to see. So please join ADN so the ADN family can keep growing. You all are welcome to join ADN and become an ADN member and become an advocate. So thank you so much for having Orega colleagues on board for this. Thank
Thank
you.
you. So now we turn the attention to the innovations and advancements in snakebite management. That is also our core area, the ORIGA research into the clinical trial and clinical research in different phase 1, phase 4. So we have that, we'll introduce one speaker, Chloe Vasquez. Chloe is presenting on new horizons, innovations and challenges, the changes in the snakebite world. And Chloe is a health economist and Watson Snakebite Research Fellow, Radiant Future Leader, based in Texas. So over to Chloe.
Great. Thank you so much for that introduction. And thank you so much, Dr. Snandu, and all of your organizing team. So my name is Chloe Vasquez, and I'm an economist, not a scientist, so please keep that in mind as I'm presenting today. But I'd just like to speak a little bit about snakebite, the present and future. So we can kick it off with the bad news first. So over the past 5 years, funding for snakebite R&D has been increasing, but unfortunately, this has been largely due to two main funders. The first is the United States Department of Defense, which has been the largest funder for snakebite R&D, but all of their funding has been going towards the development of one small molecule therapeutic. And the second largest funder has been the Wellcome Trust, which is a British charity. And they've been funding an array of different projects, including a lot of the R&D projects I'll touch on today, and also the WHO's Snakebite Department. But unfortunately, this funding is due to end in 2026. And so time will tell what the funding for snakebite will look like following that end. So the 2019 WHO roadmap for snakebite outlined 4 major projects to have the snakebite deaths by 2030. And so the first is the geospatial mapping project. You can see some images from the website on the right. And what you can do on this website is select any snake species and see the estimated distribution. And you can also see, I'll just use my laser pointer. You can also see the antivenoms that are formulated against that snake. They also did some target product profiles for sub-Saharan Africa, and these describe what antivenoms should look like for the continent. They have been working on risk-benefit analysis for the products that are already on the market, and this describes how safe and efficacious they are for the area that they're made to be working in. And they've been working on these for Africa. Some of the results are out, and they're beginning on those for Asia, and so far, none of the information is public quite yet. And finally, they worked on antivenom stockpiles. And so the groundwork has been laid for these. They'll be rotating stockpiles in Africa. And while the original plan was to have WHO initially purchase the antivenoms for these, it's looking like with the current funding situation, the countries themselves are going to have to purchase these antivenoms. But it's not all bad news. A lot of governments have started their own initiatives to address snakebite. And one of the global leaders has been India, which published the National Action Plan for the Prevention and Control of Snakebite Envenoming last year. And this is the world's first national multidisciplinary, multi-sectoral plan to mitigate snakebite. And so this has included plans such as to train healthcare providers to ensure access to antivenom, to standardize the treatment for snakebite, and also to raise awareness among other plans. And other countries, such as Thailand, have worked to improve the distribution of antivenoms. And so the Thai National Antidote Program not only improved the distribution and availability of some monovalent and polyvalent antivenoms, and this has reduced by half the spending on snake antivenoms. So you can imagine that this could be very helpful in terms of ensuring that your resources are spent very wisely. Many countries have also published national guidelines for the clinical management of snakebite. They've added antivenoms to essential drug lists, and they've added snakebite as a notifiable disease, which means that healthcare facilities must report any case of snakebite envenoming. So for over a century, we've been relying on traditional antivenoms. And these are made, as many of you know, by extracting snake venom, immunizing horses, a little bit of formulation, and then you get the product out there. The good thing about antivenoms is that we know they work, and we have regulations set up for these therapeutics. But unfortunately, they're incredibly expensive to make because they require a snake farm, they require a horse farm, a very advanced and sterile lab, and skilled workers. Besides this, the limitations is that they don't always prevent the local effects of snake venom. They don't always target all of the snakes that are present in any area. And like previous presenters have mentioned, a lot of antivenoms can cause allergic reactions and even anaphylactic shock. So that's why they must be administered in a hospital setting. But unfortunately, most snakebite victims get bitten very far away from hospitals, and so hours and hours pass before they can get healthcare, leading to many deaths and disabilities. So people are working to change antivenoms. The recipe has basically been changing so that you can use less venom to give the same immune response from horses. People are testing different formulations to see whether Fab2, or whole antibodies are better and more efficacious, and also which venoms will have the best cross-neutralization. Besides this, people are working on regionally specific antivenoms. So this is part of NAPSE. This is what people are working on in Kenya and in South Africa. And the hope is that regionally specific antivenoms will have improved potency. So maybe you can use fewer vials and have a cheaper dose with fewer vials. And you can also integrate key species that are not included. So right now, Indian polyvalent includes the venoms of the big four, but if you're bitten by a Malabar pit viper in the Western Ghats, or if you're bitten by a monocled cobra in the Northeast, then antivenom won't work for you. So hopefully regionally specific antivenoms will include these missing venoms. The downside of regionally specific antivenoms is that these could fracture the market. At the present state, these companies can manufacture antivenoms at scale, so this reduces the price per dose. But if we have regional antivenoms, this could create a situation where the price is higher. So time will tell. People are also working to revive old antivenom formulations, such as the famous Fav-Afrique. Besides your traditional antivenoms, people are working on next generation solution to snakebite. These include recombinant antivenoms, which rather than using the horse's body to generate an immune response, they can take that antibody, which is effective against toxins, and clone them in yeasts or other mediums. They are also using camelid antibodies, which are heavy chain only. And so whenever you cleave these, you can have a very small antibody fragment, and it can neutralize even very small and hard to reach toxins. They work very quickly, and so these could be more effective than traditional antivenoms. There are also human or humanized antibodies, and these will hopefully be less immunogenic and cause fewer allergic reactions. Broad spectrum antivenoms basically they lock onto binding sites on toxins that are similar across various toxins of the same family. And so you can have one antibody which neutralizes a broader range of toxins and more snake species. So these are the ones that you hear being called these universal antivenoms. And finally, there are de novo generated proteins. These use artificial intelligence to initially come up with a viable group of potential proteins which can neutralize snake toxins, and it can reduce the cost of initial discovery of these antibodies. And besides the animal side of things, you also have some chemical therapeutics that people have been working on, which are very exciting. And so these are made to target the main toxins that cause deaths and morbidities in humans. And so the hope is that if these chemicals are more field stable and they cause fewer reactions, many of them are they're drugs that existed before for a different purpose. And so now they're being repurposed for use against snake venom. And so hopefully, if they're very safe, they can be administered in the field and buy people some time as they get to the hospital, or they can be administered alongside antivenom. And so if they're bioavailable through ingestion, then that means that you could give people a pill in the field and then they can go to the hospital. Another idea would be to administer subcutaneously, just like diabetics can inject insulin, or even having a microneedle patch that people can apply in PHCs or in the field. So where are we right now? There are currently 127 marketed products, and these are pretty much all traditional antivenoms. And there are 196 candidates, therapeutics, that were recorded in 2022. But you have to understand that the vast majority of these are still in discovery and preclinical phase, and only 8 of them in 2022 were in clinical trials. And this is at a point in time where a lot of global health funds are in decline. Wellcome Trust funds are ending in 2026, and they've all been allocated. Unfortunately, my president has pulled out of the WHO, and USAID has been shut down. And so there's a vacuum where a lot of global health funds will be trying to fill these programs that we're working against HIV/AIDS and other health issues. So the big question is how we're going to fund clinical trials and take these products to market. And this is something that has been neglected up until now. So a lot of these pipeline drugs are still going to take some time to come into the market, but we're very excited to see them. And finally, it's very important that regulation and communication keep pace with the innovation that's happening, because any misuse that happens or a failure to understand the when and how you should use these therapeutics could cause a loss of faith among healthcare providers, just like we saw with antivenoms in Africa, where people felt like they didn't work and they were unsafe to use. So besides therapeutics, there are also diagnostic tests that are starting to enter the market. For a few years, Australia has had a diagnostic test, which was meant to determine which snake caused the snake bite. And these are actually quite expensive, and they're not even recommended because of the cost and also because they had some inaccuracies. So you always don't know which one. There's a new venom detection kit that's entering the market. So unlike the Australian kit, this one is to tell whether or not envenoming has occurred. And it has a much lower price, which is expected to be around $15 US. But the most important thing to keep in mind is that a positive venom detection test does not mean that you should administer antivenom. These healthcare providers must know that it could be a mild case of envenomation, or it could be envenoming due to a snake that's not included in the antivenom, so a monocled cobra or a non-big four snake in India. And besides this, there are other monovalent or test kits or other test kits which can tell you which snake was responsible for the bite. So hopefully we can see these soon. And if there's one message that I want you guys to take home today, it's that innovation extends far beyond R&D. So we got to see Priyanka Kalam's application, and things like this, they don't have to be high tech in order to save many, many lives. So I've been learning a lot about different songs, comic books, board games, which people use in schools in order to gain children's attention and teach them about snakes and snake bites. There is also creative antivenom distribution, which, like we already learned, can save costs in terms of snake bite. Also creative partnerships, such as with wildlife services or the Department of Education, can extend the impact of snakebite initiatives or partnerships with other neglected tropical diseases, for example. Besides this, making smart policy. So how can we motivate or require employers to prevent snakebite? How can we motivate healthcare providers to learn about snakebite? And then making sure that all of these interventions are based in reality, because it's very easy to make mistakes. Something that sounds like a great idea might not work on the ground. So I know that people have found that they purchase a ton of boots of rubber boots to protect workers, and then nobody uses the boots because it's very hot. And so they just never think a snake bite will happen until it happens. So you just have to think about reality and what things are like. So constantly consult actors on the ground. Thank you so much for your time. Here are a few resources if you guys would like to continue reading. And that's all I have.
Thank you, Chloe, for your valuable. Thank you, Chloe, for your valuable perspective. That and the inventions, things that your diagnostic keys and clinical trials and what is the pipeline, what is the policies, everything you have covered. So if the audience has any questions, so they can ask there in the question box and we'll answer. And later on also we can from the mail ID, if you just put the mail ID there, we'll ask the questions from all the ecosystem and stakeholders and we'll respond. So next, it will be our, the last presentations, Dr. Badal Kumar Sahu, and it is on the subject is clinical research advances in snakebite treatment, insights from the global trial. Already he has participated in 2 global trials on snakebite, and I think one of the trial he was the highest recruiter in trial, and it happened in US, India, and also one of the premier institute, government institute. So over to Dr. Badal. I'll just, in brief, I'll just introduce him. So he is Assistant Professor, Department of General Medicine, so NRSMSH, and live member of the IAP, API, RSSDI. He's having the 25 years of clinical trial, clinical experience, and 19 years of government services, 11 research publications, around 8 national and 4 global clinical trials, and out of them 2 on the snake bites. Over to Dr. Badal.
Thank you, Mr. Snendu and whole Orica team. Good evening to my previous speaker, respected speaker. Special thanks to President of ADNA, Professor Nivedita Ray Bennett, and special thanks to Priyanka ma'am for good informations, etc. And also Vaspe's good presentations. And finally, my respected teacher, Dr. Doyal Bandhu sirs, presented good informations and he also worked at West Bengal in government advisory level and also worked at the primary health center level also. Thank you all. I have 2 or 3 few words for advances in management of the snake bite. My previous speaker already solved my advances management, but I said few lines why advanced management is required, because snake bite is a acute life-threatening and also emergency medical problem, and it is the highest mortality rate also in India, in globally. But most snake bite are eminently treatable and curable. And under the ADN, our objective is snake bite death is 0 level. And how can possible 0 level? That's why some research work is required, some detections of snake venom kit separately, and individualized treatment overview. So in that case, in around 50,000 Indians die from the snake bite poisoning every year. And age is in between 20 to 50 years. In June 2017, WHO have already published the snake bite poisoning treatment is neglected. That's why in Indian currency, GDP is mildly increased 1.9% in health budget in last year, 2025 to 2026 budget. So 10% of total snake bite by venomous and 80% is non-venomous bite. So how to manage this case and how to WHO recommendation? First aid treatment, quick transport to the hospital. It is very important things. And already Dr. Dayalbandhu sir is told everything. It is a golden time also. Every patient need to be hospitalized within 2 hours, maximum is the 6 hours. Rapid clinical assessment and resuscitations. Investigation and laboratory test is needed. Clinical assessment is very much important for every individual patient because some snake bite patient or victims have recent life-threatening symptoms and signs and required to save the life. And lastly, Vespaz ma'am is told that everywhere, every corner of the world require the antivenom. Existing standard of care is antivenom is supplement is regularly. So it is important. And another 2 or 3 things is important for the smart management, smart policy. Smart policy is needed in everywhere because every worker, every government and every auxiliary and also NGO is needed to support team because snake bite is emergency treatment and follow-up is needed and sometimes require rehabilitations. It is very common flowchart in suspected snake bite patients required diagnosis. Firstly, it is a venomous or non-venomous. Sometimes patient comes in our hospital or our PSC level by overbite, sometimes occult bite. Otherwise, if patient is asymptomatic, require follow-up. And if patient is symptomatic, required it is a type of snake. That means neurotoxic or vasculotoxic or myotoxic bite. And as per toxicity required to management. Especially in Indian country, we usually 4 snake is very much common, especially cobra bite, neurotox under the neurotoxic bite, and in the vasculotoxic bite, viper, Russell viper and scaly viper is important. And sometimes also another myotoxic bite is present, but very rare. And anti-snake venom already discussed my previous speaker. And how to use anti-snake venom, how to qualitative and quantitative measurement is required, and how to preserve this and how to transport this. Everything is nicely presented, ma'am. That's why no need to explanations. So in systemic environmentation, 2 or 3 important requirement is there. Firstly, patient 20 WBCT. It is not a confirmatory test for the venomous snake bite, but it is one of the test for initial patient was poisonous or non-poisonous. So it is 20 WBCT whole blood clotting time is important parameters. Another parameters is clinical parameters, especially in the neurotoxic bite, ptosis, ophthalmoplegia, muscles paralysis, especially the difficulty in deglutitions, etc. So in neuroparalytic cases, sometimes we use the standard care of 10 vial of AVS along with the along with some drugs, especially used in India in the infusion pump. Sometimes that is neostigmine and atropine. Sometimes we look for the antivenom is safe to the pregnant or children. Yes, it is antivenom is safe to the, but sometimes it have allergic reactions, and that's why ma'am is already told how to prevent the allergic reactions or serum sickness reactions in snake venom, especially the AVS. How to manage AKI? It is very important part, especially in majority of our Indian snake is hematotoxic. That's why need some special emphasis in the AKI. And in everywhere, and even our India, there is a subcenter, there is up to the subdivisional and state hospital level, everywhere is dialysis is present. That's why every patient, if required, go for dialysis early, and sometimes also plasmapheresis. Come to uh, varisplatine, that is the newer drug, already told previous my ma'am, how to come in market and how to work, what is the mechanism of actions, and luckily I was a PI in that trial. First of all, Bravo trial. Bravo mean that broad spectrum antivenom oral preparations. Broad spectrum rapid antidote, that is oral preparation varisplatine. That is a double blind trial. That is a placebo control trial. Parallel Brevio, that is the IV followed by the oral. These two trials come in world for objective is that how to reduce the burden or consequence of the difficulties or death rate, and that is two trial we are use standard of care along side by side the IP product. In Brevio, in Brevo trial, where the oral preparations continue for 7 days, first is 500 milligram, then 250 milligram twice daily, 12 hourly for the 7 days. In the Brevio trial, it is using IV infusion followed by the tablet, where 0.45 mg per kg per hour, followed by tablet, same dose, 500 tablet followed by 250 milligram in twice daily. And after that, few data we are finalize that how to drug each work and how it is better than the IV anti-snake venom, or how it precise that it is a good drugs in the that trial, because 2 to 3 parameters is important. Patient in hematotoxic bite, patient have no required the hemodialysis, patient was not suffering AKI, and in case of neurotoxic bite, patient need no required prolonged ICU staying, etc. That's why Brevio and Brevo drug is good in the trial, but research work is going on. And ma'am already told that some small molecule, some inhibitors or some peptides is in market, but it is not in WHO recommended till now. But some that is varisplatine, methyl varisplatine already told that it is a phospholipase A2 inhibitors. Varisplatine is inhibitor of phospholipase A2. It is the venom poisonous in the snake. So that inhibitors is good for consequence of future complications, side by side in immediate complications. Another important two drugs is in market, that is peptide drugs, especially in batimustad, and also sometimes it's another drug is SBMP inhibitors, that is DMPS or dimercaprol. And that two drugs is important. It is a inhibitors, including the matrix metalloproteinase inhibitors. So these two drugs is important for preventions of the immediate complications of any type of snake bite venoms. So finally, that is the some message from my end. That is, snake bite is a syndromic approach based venomous snake identification. That is, venomous kid identification is required immediately, and that can be done in every country by some research work. And 20 WBCT is a gold standard test, but clinical observation is also important in decision making. Apply hit first and hit hard rules always. Treating doctor must be present during the first 2 hours of AVS administrations in all level from the PSC to Apex Institute. Early hemodialysis is required, especially in the hematotoxic bite. That's why need our strengthening of the primary health setup, and plasmapheresis is sometimes required for management of AKI due to snake bite. Promising newer oral agent like varisplativ is management of snake bite is upcoming in market, and watchful expectancy, meticulously monitoring, and aggressive interventions required and cornerstones of that success of snake bite management. Thank you, Snendu.
That both the trials have been completed already?
Yes, yes.
So I think it has been published. I hope the trial is published already, or both the yet to publish. Just because we are over the time, so you know that it was 30 minutes. So yeah, but so first question is to Dr. Saswata Banerjee. Okay, so Dr. Banerjee is available right now. Hi, Dr. Banerjee. Okay, fine. So later on will come. There is one question for and another questions from the audience. I'll come to that one.
Yes, yes. Am I audible?
Yeah, yeah. Okay, fine.
Yeah.
So Banerjee, one question is there that from Flo, that I saw your presentations by David Williams from WHO, which recommended whole IgGs over, saying that during digestions of our car of the FC chain, there are more IgG fragments which can also cause reactions. Is this not a widely held opinion, or why do most manufacturers still use fat?
Yeah. So from logical point of view as well, the your functional part is actually the FABDAS, which actually binds with the receptor side, or in this case, it is the venom. So there are multiple publications. I have given the answer to that. That if you only keep the part which is required and just the species related part, which is very understandably the uh, foreign to the body, so that could cause more reactions. So there are multiple publications, be it a dengue antibody, anti-rabies antibody, which are extracted from the horses, and of course with the ASV as well, that the whole antibody is more, has the propensity to cause the reactions compared to the only part of it. And during that, one of the concern could be during the digestions, there could be multiple small fragments which can cause a potential reactions. But there are purification methods which actually eliminates most of these smaller fragments, and only keep the one which is the majority of the one which actually there. And since you are eliminating all those, you are reducing the chances of the reactions as well. Yeah, over to you, Mr. Snendu. Yeah. I think Dr. Dayalbandhu Majumdar, if you have any comment, or Dr. Badal, if you would like to add anything here.
No, sir. No, sir.
Okay.
You
So,
absolutely right, sir.
okay, fantastic. So
Thank you.
just if Glow, your answers is clear, I think.
Yeah, I have just one quick follow-up. Yeah, I've heard that answer. That was the standard answer that like publications before were always recommending to chop off basically the FC portion. But I've been seeing that some other publications more recently have been contradicting that, and that in more clinical trials, the whole antibodies, antivenoms haven't been having as many reactions compared to some other Fab2 products that are on the market. So is this just product specific, or I'm just curious, like in what we're seeing on the ground, why are we seeing more reactions with Fab2 products?
I need to look at the publication you are referring to. Is that related to the ASV or some other disease as well?
These are ASV. I can send you the
ASV.
presentation which references
Sure,
these
sure.
from David Williams.
Yeah. So historically, we started with the whole. Then we had the newer technology move to the FC. Sorry, Fab-2. And reason being the reactions is one of the factor, and efficacy, and you require the and second part is the burdening the human body with the more protein elements, which will create the burden on the kidney for elimination of those proteins. So these are all interlinked. So I really need to look at the data. I'm not aware of it. So what you are referring to, so what is the patient population? So what are the age group? What was actually happened? Follow up of those patients, like how many of them had any kidney related complications, like AKI or any sort of. Those are things are also considerations other than the immediate reactions in the form of either anaphylactic or milder form of the adverse reactions. But currently, this is the practice across in most of the most of the manufacturers, biologic manufacturers. And the researches are going on, as in your presentation as well, moving towards the lighter molecules, which are even more effective, like the nanoparticles or any proteins, which are more effective and more specific. You don't burden with too much of proteins or the amino acids.
Thank you. Thank you, Dr. Sasi, for your elaborative and answers and clarifications here. So next, if we come that if anybody any questions, because there are one more questions for the VAS page, but it has been replied with VAS page personally in his message I have seen. And from Asia Littner, there is of course, I have seen that you have one requirement, so we'll also get back to the, with the answers from the primary and secondary stakeholders. And there are no more questions here in this message, but still, if you have any questions, and I think, Kelly, that the audience can also unmute and ask the questions. Do you have facility if you can give that option? No? If no, then later on we'll take the questions and respond accordingly. And if any of the speakers, and if you have any questions or hear from the audio team, that if any questions to the speakers or anyone, we can ask, and otherwise we can conclude here. Okay, fine. So I hope that there is nothing. So if before conclusions, if any speaker wants to say, or any from audience also, I'll ask that if anything you want to say something or any note, it is welcome that we can give 2 minutes time and then conclude.
Special thanks to Orica team, and also special thanks to Snendu.
Yeah, thank you, sir. Welcome. So we'll and we'll that this type of initiative will take on site also with planning. I reward with Dr. Saswat also So I think it is a good thing that if we can set a program on site also in any of the locations.
Yeah, I think the same thing echoes. Special thanks to the entire Origa team as well as the Avoidable Date Network. If Dr. Nivedita is still there, or everyone from the other contributors, Dr. Badal, Dr. Dayalbandhu Majumdar sir, and overseas faculties, Flo, as well as I find Lipner is also joining. So thank you so much, and everybody those who have attended it, and Priyanka Kadam.
Thank you. And I request Dr. Manish also to for the conclusion, please. And that's the end of the video.
So thanks everyone. It was a wonderful session. And the last I would like to say that we have to convert this technicality into reality. And that is the takeaway that I think one line takeaway forward. And we should frequently connect through different mode for different purposes so that this momentum should be there and we should have a feasible, sustainable and workable outcome. Thanks. Thanks, Father.
Yeah, thanks all.
Thank you,
Thank you to
everyone.
all. Thank you all. Thank you, everyone. Thank you.
Thank you
Thank
very
you.
much. Bye-bye.
Bye bye.
Bye.
Bye bye.